Well, good afternoon to everybody. Welcome to the Primary Spine Provider Network webinar series. Today, we are very excited to have the World Spine Care team and Geoff Outerbridge leading that team in discussion today. Just a few housekeeping pointers before we begin. For those of you who are on the Zoom webinar, feel free to raise your hand if you would like to participate at the end in the Q&A. We will unmute you and you can actually speak your question or comment. Also, feel free to use the chat. We will enable that shortly. And then for those who are on Facebook watching there, feel free to post your comment there as well. We will monitor the chat and we will include your comments for the team here as well. With that, over to our team member, Dr. John Ventura. John.
Thanks, David. I'll briefly introduce two of our speakers today. The first, Geoff Outerbridge. Geoff received his Bachelor of Science and Master of Science from University of Guelph, which I've driven by but never have stopped in, over by Toronto, and received his DC degree in 2001, I believe, 2001 or so, from CMCC. And Geoff is the current co-owner of Beechwood Physical Medicine in Ottawa, Canada, a multidisciplinary organization, and the former clinical director of World Spine Care, which is what he's going to talk to us about today, which was really the brainchild of Scott Haldeman as a way to bring first-class spine care to people in very underserved communities around the world. He currently sits on the board of World Spine Care, and during his tenure working with them, helped to open clinics not only in Botswana, but in Mumbai, India, the Dominican Republic, and Accra, Ghana, which I believe all those clinics are still operational. And additionally, someone who's going to talk to us about volunteer opportunities with World Spine Care is Kate Graham, who runs that program. And she currently is in practice. She's a 2015 graduate of CMCC and currently in practice also in Ottawa, Canada. So with that, I'll let Geoff and Kate take over.
All right, thanks, John. I'm just going to...
You should be able to share your screen if you need to, Geoff.
I'm working on that right now. I just have to play with... all right, let me stop that. Hold on one sec.
Okay.
I got it. There we go. Okay.
There you go.
That's actually not what I want to do.
Oh.
Sorry about that. I've got to play. Okay, there we go. Now I want to do that. Okay. So are you guys just seeing a single slide, or are you seeing my presenter notes?
No, just a single slide.
Okay, that's what I'm looking to do. Good. Okay. So thanks for your interest and thanks for the invitation to do this presentation. World Spine Care has been around a long time, and we've been through a lot. So what I want to do is go through a little bit of the background of, first of all, why World Spine Care came into existence, and then kind of relate it back to that primary spine provider concept that sort of was originated by Scott Haldeman, and how maybe a little bit how that evolved and how that actually drove what we did with World Spine Care and what we've created with World Spine Care. So, with all organizations, we kind of have to justify why we exist and why World Spine Care was created. I feel like I'm preaching to the converted and those who know, but I'm going to go over just some really basic statistics about spine problems. There's 1 billion people worldwide who suffer from spinal pain. Global Burden of Disease study provided evidence of the impact of musculoskeletal conditions, highlighting the significant disability burden associated with these conditions. while the prevalence of musculoskeletal conditions varies by age and diagnosis, between 20 to 33% of people across the globe live with a painful musculoskeletal condition, and 1 billion of them suffer from spinal pain alone. Low back pain remains the single leading cause of disability since it was first measured in 1990. And it contributes, low back pain alone, contributes more to the global burden of disease than HIV, diabetes, malaria, stroke, lung and breast cancer combined, lower respiratory infections, and traffic injuries. I could go on and on about all kinds of other statistics, but they tend to be kind of numbers that often don't have a lot of meaning, or it's hard to understand that meaning. The prevalence of the spinal pain is also much higher in low and middle income countries. And not only is it significant, but it's also one of the most significant healthcare issues throughout the world today, and it's getting worse, particularly in low and middle income countries. And we can talk about the statistics, but what's also important is the actual personal impact. Statistics only really tell one part of that story. When somebody has low back pain, it's not just the pain that they're experiencing, but there's a loss of independence. It becomes a reliant on other people, and that can lead to a loss of social identity. There's a Setswana expression, matlo hoshamabapi, which directly translates to houses burn together. It's that idea that what happens to you will affect me, and what happens to me will affect you. So we kind of have to work together and support each other. And that ethos is something that is very strong in communities and rural settings in low and middle income countries. And a person's identity is pretty much tied to how helpful they are and how much they can contribute to that community. And they'll often work hard through pain to contribute, but if the pain stops them, they lose that social identity. And because back pain's kind of invisible, often they're sometimes seen as lazy and a little bit shunned by the community. Also, in villages, there's often a village exodus, and the sort of middle-aged, able workforce is sometimes forced to leave to find work in urban areas. And so it's the elderly and the young who are left behind, the older caring for the younger. And so this kind of compounds the problems for a caregiver who has pain. And when one person's removed from that workforce, others in the community have to care for them, but also bear their workload. And in most of the low and middle income countries that we worked in, they usually present to the emergency room. There's usually really long waits. MDs have little time and no specific knowledge regarding spinal pain. So there's usually like a cursory exam, and then if they have access to imaging, there will be imaging, and then they're given medication and sent off. In some countries that have physical therapists, they may be referred to physiotherapists, but lots of countries don't have those available. They're also kind of in a biomedical model still very much. There's no recognition of psychosocial issues, no prevention, no self-care strategies. So the patient ends up coming back to the ER, getting more medication, more imaging, and it just that cycle kind of continues with no resolution. And in Botswana, because that healthcare system is reasonably well funded, each patient pays about 5 pula or 25 cents. I'm not sure if that's changed, for any visit. And with that, they get medication, they get imaging, and so what happens is this leads to over-imaging and over-prescription. So we would see patients who would come in and they would have stacks of x-rays, many of them duplicates of the same body parts within a year. So they would go to a different medical officer each time, different or orthopedic surgeon, but usually a medical officer, and then the next one would order another set and give more medication, and that just continued. So that lack of care continuity leaves that patient seeing the different MD all the time, and it just is a never-ending loop. In other countries, like in Tanzania, there's difficulty in funding, so they don't have access to the same sort of care. So the care gets divided depending on whether you have money or whether you don't have money. And if you have money, they get this higher cost care, and the belief is that that imaging and medication and all kinds of diagnostic tests are better for you. And so that's what they would end up getting, which doesn't necessarily lead to better care. But if they don't have the money, they would end up going to traditional healers, and there is no sort of in between and no evidence-based care within that. In a lot of villages, the traditional healers or bone setters were really the primary contact for spinal disorders or spinal pain. And that kind of led to this wide range of care, from spiritual interventions to care that essentially followed current evidence-based guidelines. When I was looking at to develop a clinic in Ethiopia, and I interviewed a bone setter in Ethiopia. And after the interview, it pretty much seemed like he was providing evidence-based care. So, the question then was, well, do we really need to be here? Or also, the better question is, what can we learn from those sorts of traditional healers? So we have this huge global burden. It's worse in low and middle income countries. We have significant personal and societal impact, and a condition that's really poorly managed. But there's also issues in high income countries. And for those of you who've listened to Scott's presentations, I'm stealing his idea. But in high income countries, there's a proliferation of treatments for back and neck pain. And Scott uses the analogy of a grocery store or a supermarket. So this current approach to selecting interventions is like walking into a supermarket. You've got this large inventory of treatment options grouped into aisles. So, the right-hand aisle might be exercises, the left one might be medications or manual therapies. And then within each of those aisles, there's numerous types of treatments available in every category. So under manual therapy, there would be massage or acupuncture, spinal manipulative therapy. There may be different types of injections, cortisone, PRP, prolotherapy, and so on. And then within each of those particular sections of the aisles, they're further divided into competing brands, which is usually different clinicians offering those different services. And they're largely differentiated strictly based on advertising and not really on quality care. And this is a big sort of gap we have in our delivery of musculoskeletal care, is it's really difficult to identify when somebody is providing quality care. So from a consumer point of view, you have no idea what to do, where to go, what kind of practitioner to go to. Many clinicians have no idea of the efficacy of treatments that they render, or they only look at the economics of the treatment and not really the efficacy of the treatment. And this was a slide of Scott's that shows just the initial list of all the different interventions for back pain. And this is just a partial list, and I'm sure that's probably doubled by the time he created that list. So considering the burden, the lack of access to evidence-based care, the endless list of options for consumers to navigate through, how do we tackle these issues? And so it's been Scott's mission to find solutions to these problems for spinal pain in both developed and now developing countries through research and evidence. Being a chiropractor, neurologist, PhD epidemiologist, he's really the only person who could have bridged that gap between all the stakeholders in the spine care world. And so he went about tackling this problem by developing the concept of what he called the primary spine care clinician, and then by creating World Spine Care. So in terms of the evolution of that concept of the primary spine provider, or he started out with primary spine care clinician, is he wrote an editorial in the Spine Journal in 2001, which sort of introduced that concept, and then presented at the American Back Society annual convention in 2005. And then Don, hi Don, saw him on the call, established that primary spine provider network, or talked about the establishment of the PSP and the benefits to healthcare reform in the US in 2011. And then Jan Hartveson also wrote in the British Medical Journal in 2001, we need to rethink frontline care for back pain, and talked about this similar concept. So I kind of got brought into this in 2014 and participated in a couple of the PSP seminars. And in the same year, Scott and Don and I created the Wikipedia page for primary spine providers or primary spine practitioners. And I remember sitting down and talking about, well, what is the real terminology that we should be using. And Don obviously was already using primary spine provider. And so Scott kind of dropped this primary spine care clinician, and primary spine provider took over. But from the very start of the meetings that I had with Scott, I went down to California for about 5 days in advance of going to Botswana. And we sat down and we started to work out the whole sort of clinical program, data collection, and everything. And that was very much built on the foundation of that primary spine care clinician model that he had envisioned and written about by that time. So a little background on that. Because the primary treatment approach to 90% of back and neck pain are manual therapy, exercise, education, and including psychosocial interventions and mild analgesics, it makes sense that the person who's going to do 90% of the care, or the care for 90% of the patient, should be that person who is also the primary contact, and instead of having people bounce around all kinds of healthcare practitioners and eventually end up with the person that they're going to get treated by. And these can best be offered by chiropractors, physiotherapists, or osteopaths with advanced training. But they have to be knowledgeable about best practice. They have to remain current with recent evidence-based guidelines, and must be aware of the indications, benefits, harms, and costs for all spine-related diagnostic tests and therapies, hence understanding all the shelves of the grocery store. So they also have to have a set of skills and knowledge, and that has to include being able to do an adequate history and screen for red flags, physical examination, neurological examination, be able to diagnose, and then categorize spine pain into the categories of neurological, pathological, rheumatological, and then coordinate care with referrals depending on whether it is something that's degenerative, congenital, neurological, and so on. Then be able to provide the manual therapies and conservative care, including exercise, healthy living, wellness, education, and addressing psychosocial risk factors, and also sort of recognizing mental health issues and being able to refer out for that as well. And then the expectations are that they will refer for testing according to evidence-based guidelines, understand the indications, benefits, and risks of spine surgery, and refer to surgeons, create sort of relationships with local surgeons. The same with rheumatologists, being able to identify systemic inflammatory joint diseases and refer when necessary, and then be able to identify psychosocial and mental health issues and make appropriate referrals. So that's a heck of a lot of knowledge and skills that somebody needs, which is why the PSP network, Primary Spine Provider Network, and the training that is being offered is so important to sort of support and ensure that the providers have that resource and ongoing education. So this was sort of a slide that Scott used very early on, and this was the model that he saw with World Spine Care. It was a multidisciplinary approach with that primary spine care clinician, or PSP, being the quarterback, the central command, and sort of making the decisions and referring out to community resources or tertiary care or rehabilitation. So that PSP was somebody who played a central role in full management and coordination of that patient's care. So at the time that we started World Spine Care, this was a great idea, but it really was just an idea. It hadn't really been adopted to any great degree, and it hadn't been tested. So the idea of World Spine Care was, first of all, to address this burden. But if we're going to address this burden, we needed to make sure we were using this model based on that principle of the primary spine provider. And the low and middle income countries, particularly Botswana, where we started, was a really good place to start because, number one, we weren't fighting turf wars, which always gets in the way. There was a decent infrastructure in their healthcare system. There was an enormous need, and we could sort of start from scratch and start to build things and then test that model. You don't want to just build it and do it. You got to make sure that it's actually doing something productive. So we had to test the model and demonstrate that it can impact the current health and financial burden of spinal disorders, basically on society and in low and middle income countries. Now, that was just a few short sentences, but that was a huge, tall order, and it's still an enormous, tall order. As I go through the rest, you'll see it's saying we're going to do this and then actually doing it and having a having any success at it are two very different things. But that was the ideal when we started, and off we went. So World Spine Care began in 2009, and then started in Botswana in 2011. My job was, as the clinical director, to set up that first clinic and implement that model, and start to set up the data collection and data analysis protocols as well, and hope to validate the model. So now World Spine Care is, it's a multinational nonprofit charity registered in the United States, Canada, and Europe. And to date, we have 5 executive members, 2 administrators, 17 members of the research committees, 12 members of the clinical and scientific advisory board, 5 members of the fundraising committee, 23 prior and current clinical supervisors, and 30 prior and clinical volunteers. So we've had a lot of people involved, a lot of amazing help, and things have really moved along quite a bit since 2009, when that idea sort of first started and I first got involved with it. Mission to bring sustainable, integrated, evidence-based spine care to underserved communities throughout the world. And underserved isn't necessarily low and middle income countries. You can find underserved communities within high income countries, and you'll see it's basically wherever evidence-based spine care is not reasonably available. And then our vision is a world in which everyone has access to the highest quality spine care possible. So currently, these are all the locations of, I'll say projects, because not all of them involve clinics. And I'm going to go through each of them, but we have a nationwide spine care program that we're working on in Nepal, a clinic in Navi Mumbai, Accra, Ghana, Shishong, Mahalape, and Gaborone in Botswana. That's where sort of most everything is going on. We've got Michael Pretorius on the call with us, who is one of the clinic supervisors in Mahalape and Shishong right now. And then Mocha, Dominican Republic, and Cross Lake or Pimicikamak in Manitoba, Canada. So Shishong, Mahalape, this was where we began. And I first started in 2011 there, and we opened a clinic in the Mahalape District Hospital, and at the same time started work on building the Shishong Clinic. And Shishong is a small village about 40 kilometers from Mahalape. Right now, Michael, who I just mentioned, is in Shishong and Mahalape, working at the 2 clinics. And Patrick Boylan, I'm not sure if he's on the call, but he's one of the primary spine providers, is going to be around until next summer. And there's a 3-bedroom house there, and they just moved into a new clinic in Mahalape called the Moko Clinic. It looks fabulous from the videos that I've seen. And this is one of the locations that, if anybody's interested in volunteering, there's lots of opportunity in Mahalape and Shishong. And Kate can talk more about the volunteer opportunities later. Then there's also Gaborone, which is the capital. We had a clinic in the Princess Marina Hospital, which was the main referral hospital. And at that time, we were actually part of the orthopedics department. So we were very much embedded into the healthcare system within that hospital, and we're very active in working with the orthopedic surgeons and almost trying to triage patients before they went into surgery to ensure that they really needed surgery. So Mufudzi is the one who's running the BH3 clinic in Gaborone. And so those are the 3 Botswana clinics. And that's have been running ever since we started opened the first clinic in 2011. Then there's the Greater Accra Regional Hospital in Ghana. Afua Adjekwaisi is a medical doctor, and then went to Palmer College Chiropractic and got a DC, and went back to Ghana and reached out to us and said, I'd like to try to set up a nationwide spine care program in Ghana. And so I went and spent a week with her and trying to build that model and set up a clinic in the Greater Accra Regional Hospital, and she still does part-time work there. One of the difficulties when we talk about developing programs is in every country you can go in and you can get all kinds of support when you're first there. But when administration changes, that you always run into difficulties if the new administration isn't as friendly. And we ran into this in Botswana, where the initial ministers of health were extremely enthusiastic, and then change of administration, and we ran into difficulties, and then change of administration again. So when and similar things have happened in Ghana. So it's not always easy. You can't just sort of engage with the government and everything always runs and progressively gets better. Things do shift and change, and you've got to be able to adapt and try to, resell yourself to new administrations. So it's just one of those things that happened in Ghana as well. Mocha, Dominican Republic, were associated with a hospital there in a rehabilitation clinic right behind the hospital. That's been running since Christmas 2014, and has continued since then. And of course, everything stopped during COVID. Glorma Diaz from Puerto Rico is currently the clinician there. And this picture is Scott on the left, and Dr. Lopez, who is sort of our local medical doctor who helped bring us down and get us set up. Pat Tavares, who has taken over as the clinical coordinator for World Spine Care. And then Stefan Eberspecker, who ran that clinic and then the Botswana clinics he was there for about 5 years in total. And he's now working at my clinic in Canada, Ottawa. In the Mahatma Gandhi Mission University of Health Sciences in Navi Mumbai, India, it's actually a school of physical therapy that is in an orthopedic hospital. And we were sort of brought in to implement our model of spine care within that physiotherapy department. So all of the clinicians and clinical supervisors are local. We only sort of come in and provide clinical support for them, but they're pretty much running that on their own. And that's, I can't remember when that started, but it was 2016 or something. Kate, you might remember. And then more recently in Cross Lake, or Pimicikamak in Manitoba, Canada, this is an Indigenous community that it's actually Jennifer Ward is the chiropractor up there. She's on the far right. And for those research nerds, you might recognize Andre Boussier in the back, the tall one, and then Steve Passmore on the left. This is actually more where the Global Spine Care Initiative has been implemented, and they're collecting data, and it's actually funded by the government of Canada. So there's a real, that was a real exciting change when we got funding from the government. And that's that one. And then the last one here is Nepal. So we were approached by the neurosurgeons of Nepal. Amit Thapa was the neurosurgeon who approached us, and he had read the Global Spine Care Initiative and wanted to implement it in Nepal on a nationwide basis. And so he contacted Scott and learned about World Spine Care. And so we were invited to come and help sort of develop that program in Nepal. And the difference is that we're actually acting more as consultants for them to develop their own program rather than necessarily setting up clinics and trying to fund them with foreign clinicians, more helping them set up clinics and using their own. And this is the Karnali Academy of Health Sciences in Jumla. And they have a medical school and a physiotherapy department as well. So there's lots of physiotherapists to sort of train to provide those services in Nepal. So we've been at this for a while. And what are some of the things that we've learned from this? Spending more time with patients to do a more comprehensive history and exam is definitely something that from the very beginning we realized was extremely important. Patients get the time that they need. And then the follow-up and continuity of care was really important because there was one patient with multiple clinicians. We had to develop ways of maintaining a seamless continuity of care between all of those clinicians. So we had to set up a toolkit that would facilitate that continuity of care, collect demographics, comorbidities, presenting complaints. And that was part of all the research and data collection that was developed. So also, it's not just spinal pain. We see a lot of other conditions. And in the first few years, the first couple of years that I was there, these were conditions that we didn't just see, we actually diagnosed these conditions. And so, being being well trained in that primary spine model, you're better able to actually diagnose things that are outside of just low back pain or just neck pain. And you have to be aware of that. And they can present with any conditions, but you also have to have a clear understanding of that biopsychosocial model, because when you go to another country with different culture and different language, you have to understand the biopsychosocial model and then be able to modify it and adapt it and kind of massage it for those local conditions. And so the higher rate of pathology, often the reason we end up diagnosing them is because often the medical officers miss stuff. And because they're having very short appointments, they're just sort of doing x-rays and imaging, they often miss diagnoses. So you don't necessarily have to know everything and know every pathology, but as a clinician, you have to at least be able to recognize that something's not right, and maybe we got to investigate this more, and who should I talk to, or where should I go and get information? So this is one example. This was part of a case series that we published with Ismat Kanga, who is also at the clinic. And this was a patient of mine. And the patient was presented with severe low back pain that was diagnosed as osteoarthritis by the MDs. And this was the image that they first sent to us. And obviously they weren't very diagnostic. And when the patient was on the table, he had extreme pain, and any pressure over that sort of L5S1, and he was jumping off the table. That didn't seem right. The x-ray wasn't very diagnostic. So we sent for a second x-ray, and this is what we saw on the second better x-ray. And it was clearly not osteoarthritis. And at that time, we diagnosed that with TB. But what was interesting is there were no constitutional symptoms, never been exposed to TB. Also, this is not the typical area to find TB. It's usually in the thoracic spine. So it was definitely not not something you would think of in just doing an exam. But the fact that the patient had such intense pain and the imaging was so terrible, this ended up being the diagnosis. So being able to recognize that kind of pain is unusual, that imaging is not acceptable. These are the sorts of things that are enough to put you down the road to doing the right thing. And he was put on TB medication and did very well. And then he was also sent for MRIs. And then this was MRI that also confirmed the diagnosis of tuberculosis. A couple of other cases. So this was a 6-year-old girl who was the daughter of a friend. And when I saw her, I asked about it, and they said, she'd been taken to the medical officer a couple of times, and they said, well, if it doesn't hurt, then just don't worry about it and get on with life. And it's interesting, I had last thought or heard about Sprengel's deformity in 2001 or 2000 when I graduated, and here I am in 2012 looking at this going, I remember something about that. And it popped into my head, it was Sprengel's deformity, and then went and researched it and kind of went, okay, we've got to do something more, because where there's one congenital anomaly, there's often more. So we decided to do the further investigations, and with the first x-ray, we saw that there was situs inversus and also cardiomegaly. And then we did a lateral as well and saw clipophile, and then did another image to look at the omovertebral bone from the Sprengel's deformity. Then we did an abdominal ultrasound and found there's total situs inversus, and often associated with clipophile is horseshoe kidneys, and one of her kidneys was a horseshoe kidney that was tucked in behind the urinary bladder. So we did more investigation to see if that ureter was patent, and then sent her for a CT to see if there was any instability in the cervical spine. And then we sent her for an echocardiogram to see if there were any congenital heart defects, which are also associated with clipophile syndrome. But I had gone by the time, and I wasn't sure what the follow-up was on that. So again, just that little bit of knowledge and research gets you through, and it was quite important for her to know all these different things about herself and the future. And then the last one was a 25-year-old female who'd been in a car accident 8 months earlier. Her head had hit the windshield, but she didn't have any neck pain after the accident. She had just had low back pain. She went to the medical officer. Medical officer did x-rays of the full spine. Didn't mention anything. She presented us with a low back pain, and doing our due diligence, we looked over all of the images and noticed that her dens was fractured. And because she didn't have any pain, we thought, well, let's see how stable it is, and did a flexion extension. And it was quite unstable. We probably shouldn't have done the flexion extension, but she had been moving for 8 months without any problem, and it was extremely unstable. At the time, we didn't have a spine surgeon in Botswana. Now we do, who is trained through the World Spine Care Program. But eventually she was sent down to Princess Marina to the orthopedics department. So also there's always regional diseases in the different countries. In Dominican Republic, chikungunya, malaria, and dengue, these can all cause myalgias that are important to understand. In Botswana, there is malaria, HIV, and TB. And then in India, chikungunya was also endemic, and skeletal fluorosis. So we worked with the local medical doctors a lot in trying to understand what are the local endemic diseases or conditions, common conditions, even genetic conditions that might be very prevalent, and try to understand what we may encounter, so that when we see it, we're more likely to pick it up and be able to refer to those doctors. But again, like most places, 90% of what we see is that non-specific pain. And as you know, we've got these are the definite do's, these are the definite don'ts. Those are sort of our goalposts. But what we do in between is sort of a gray area with weaker, let's say, evidence. And so we know that education, exercise, and manual therapy, psychosocial interventions, these are all important as in that gray zone. But how you apply that in a country where you don't speak the language and you don't understand the culture or the beliefs becomes much more difficult. And this is kind of a concept that you need to be extremely diligent or extremely adaptable to other people's beliefs and ideas. And even though we were doing this in low and middle income countries with very extreme cultural or issues or beliefs, which I'll talk about more later, it's still something that applies to patients that we see every day in our clinics in North America. That idea that we have to adapt to them and not try to have them adapt to us. I call that chiropractic colonialism. But this musculoskeletal pain is sort of this black box, and we know what to put in: exercise, education, manual therapy, or whatever, and we don't quite know what's in the black box, and then we see what comes out the other side. And if the outcomes are positive and sustainable, then we've done the right thing, whatever we believe is happening inside that red box or black box. So the important thing is really focusing on the outcomes. So in our clinics, we would deliver outcomes after each of the first 3 treatments, and then every third after that. So number 1, we would have a pretty good understanding of the outcome if the patient just self-dismissed or self-discharged. But we also would be able to track the outcomes and find out whether that patient was actually going from treatment to treatment, getting better, and then modifying on the fly all the way along. And that should be sort of a way that we practice in general, but we had to be very diligent with that and actually make our documentation support that along the way as well. So I want to talk a little bit more about some of those specifics in dealing with patients with different cultures, different beliefs, different languages. So in most of the places that we treated, patients often feel that the clinicians don't really understand them or don't give them credit for knowing their bodies. And they use a biomedical language that they don't really understand. That's one type of patient. And then there's the other type of patient who's like, why are you talking to me? Just heal me. You're the doctor. Why are you even asking me anything? So we kind of have these 2 extremes. But more in the rural villages. In the urban areas, patients are usually sort of indoctrinated into a biomedical terminology, but in the villages, they're not. So how do you actually communicate ideas on a very simple level that they can understand? So you have to take time, again, asking questions, getting a clear understanding of the patient's experience, open-ended questions, and giving the patient to tell their whole story. Interpreters, because you're sometimes working through interpreters, you have to actually make the interpreter understand that. So early when we'd work with interpreters, we'd ask them a question, and they would ask the patient the question, and the patient would talk on for 5 minutes, very animated, talking about all kinds of things and pointing all over their body. And then the interpreter would turn back to us and say, yes. And so we'd have to go back to the interpreter and say, no, actually, I want to know everything they said in detail, exactly what they said. And that's the important thing, to get the information from them and not just sort of sweep it underneath and say, okay, yeah, got that answer, on with the next one. It takes a lot of time. Also, as clinicians, we try to learn the language, their beliefs, their goals, their customs, and patients feel they're being heard, and they also like to laugh at us as clinicians when we try to use their language. And it breaks down those barriers between the clinicians and the patients, and they feel that their culture is valued by the clinicians. You're kind of meeting the patient where they are. And so we also try to learn local expressions. Patients in rural areas learn basically about the inside of their body based on animal slaughter. So they can see veins and blood flowing. So they think that it's also what's occurring when pain radiates. They feel like pain is actually flowing down a vessel. It's a fluid flowing down a vessel. So understanding their understanding of flesh and bones, and sinew and veins and arteries. And then also using local expressions that are very cultural. So in asking somebody to relax, in Botswana, you can use the expression "kobakhetsi," which means poke the sack, literally translated. But when they put milk in a sack to curdle and form cheese, that sack is very bloated. And when the cheese is already curdled, and they poke the sack and all the fluid flows out of it, and the sac relaxes and releases. So it's become an expression to get somebody to relax. And often when you ask them, "Hobotoko hakai," or "where is your pain?" they use these big sweeping motions. And it's all around here, and you have to say, "Supakamanwano," point with one finger. I want to know exactly where the pain is, and help to direct them. But the more you can use their language, the more they appreciate that, and actually have a good laugh at you. Also in the low literacy areas, where they're very low literacy, like no education, they won't necessarily know distances or times. Like, can you walk for a kilometer? Can you walk for a half hour? They don't really know. So you have to use local landmarks like the hotla or meeting place, or the grocery store. Can you walk there, knowing that it's 500 meters or so on? And also difficulty understanding the concept of averages. So when you say, "Oh, on average last week, how would you rate your pain?" You can't really ask that. It's more, how do you feel right now? How would you rate your pain right now? And they'll often usually attribute their pain to hard work, and describe it as sort of an insidious onset. And again, some don't really know they don't care what's going on in their body. They don't want to know about it. They just like, "You're the doctor, you heal me." And beliefs vary dramatically from country to country and region to region. So one of the examples, in rural Botswana, some patients present to the clinic and believe that their back pain is due to a curse. So you can't kind of go, "Nah, it's not a curse. This is what's going on in your back." You have to, again, meet them where they are and say, "Okay, well, if you think it's a curse, have you been to your Sangoma?" And if they haven't been to their Sangoma, you have to encourage them to do that, to deal with the actual curse. And then maybe in the meantime, we can help you make a little more comfortable, and then apply what you know as evidence-based care, but not have an impact on their beliefs. And in that situation, you can have all the best available evidence and know exactly what to do with that person. But sometimes you got to throw that away, because you don't want to have any impact on those beliefs, and sort of modify it to the best way you can. Or you can actually sometimes take those beliefs and use them to your advantage. So in Botswana, as much as they believed in curses, it was very Christian oriented. So sometimes when you were trying to get patients to do a little more activity and they didn't really want to, you could always say, well, you know that God helps those that help themselves. So if you understand how they believe, you can kind of, or what they believe, you can use that to your advantage, but you definitely don't want to change it. Now in India, there were also some interesting beliefs. They have the overlying understanding of health in the very rural areas. Again, these are very rural areas, which we did work in, but we were mostly in more urban areas where, again, they're more indoctrinated into a biomedical model. But in the more rural areas, it's based on a sort of blood volume and blood flow and blood purity. So this is an Ayurvedic concept. So everybody's born with a certain amount of blood that decreases as you age. So your capacity to do things decreases as you age, but it also, the more impure it gets, the less your capacity. So you can either have less blood or less pure blood. And the way you can purify your blood is through better nutrition. But as you get older, your blood flow decreases, which means your stamina decreases, which means the muscles aren't as good and you can't cope with the same amount of work. So after about 50 to 55, they feel that almost everyone has a low back pain and it reduces what you can do along with the blood flow. And at work, they're assigned less work. It leads to some degree of depression, makes them feel worried about that they cannot make as much money as they used to. And they have to give some of the work to others. And they also feel inferior due to that reduced work capacity. So there's also a belief that after 50, the bones just get stiff, that exercise is less an effect or actually has an adverse effect on it. So basically, as people get older and, 50, 55, they just stop doing things because they don't think that they can. So the question is, how do you face that and try to get them more active without actually impacting those beliefs or overcoming that fear that if they try to exercise, they may make things a lot worse. As well, in another example in rural India, this is more customs. A young woman came to see us in a rural clinic with her mother-in-law. And in her history and clinical findings, they were really inconsistent. And the Indian physiotherapist we were working with came out and just said, like, nothing's making sense. And I went in and asked the questions and went through the physical exam, and nothing seemed to make sense either. And finally, the Indian physiotherapist turned to me and she said, you know what, I think I know what's going on. She said, in India, when a woman gets married, she moves in with her in-laws and is expected to take care of them, to cook and clean and take care of the family. And she thought that this woman was trying to use her pain as a way of getting out of those obligations. And she kept asking us for pills. And she said, well, if she walks home with pills, that's her justification that she has pain and that she doesn't have to do the work around the house. And that would sort of validate her pain. So here we are in a room with a mother-in-law who's waiting to see that she's not in pain and her trying to prove that she is in pain. And how do you kind of deal with that scenario where you know that if she does have pain, she needs to stay active and not sit around and do nothing. But if she doesn't have pain, you can't throw her under the bus in front of her mother, or mother-in-law. So these are the kind of things that you have to kind of negotiate and dance around without actually, again, giving too much of your information about this is how the body works, or trying to educate them too much. Because the question is, when does education become colonialism? Where is that line where trying to educate somebody actually messes with their beliefs too much? So we still have a long way to go to make this model functional and universal and have some sort of a significant impact on the burden of spinal disorders. But it is a worthy and honorable journey. And Scott started this a long time ago. So many of us have gotten involved and have jumped on board and helped along the way. And we're still looking for more and more people to get involved, either as clinicians or as volunteers with fundraising, with donations, with creating your own fundraising events, and so on. So Archbishop Tutu was a member of our advisory board and was very supportive of us financially and in spirit throughout the first 15 years of World Spine Care. And he's right in that if we can all do a little bit, then those little bits put together will overwhelm the world. So I would encourage all of you, if you like what you've seen, you can get more information on the website. I'm going to let Kate talk about volunteer opportunities, and then afterwards, if you have any questions, we'll go from there.
Go right ahead, Kate. Thank
All
you so
right.
much, Geoff. Yeah, go right ahead.
Thank you, Geoff. So we are always actively recruiting for short-term and long-term volunteers, primarily in Botswana and in the Dominican Republic. The opportunities range from anywhere from 3 months to a year or more. And ultimately, there are some differences between both of those locations. So if you are interested, I encourage you to visit our website. There is a volunteer page with more information and then an opportunity to reach out to us. Happy to set up a call with anyone who is interested to provide more information. And at any point, if there's a real interest to speak with any of our on-the-ground volunteers, our current volunteers, so Gloria Mar, who is in the Dominican Republic, Michael Mafudzi, or Patrick in Botswana, we can do that as well.
Yeah, and also for those who cannot take the time to volunteer as a clinician, there's always the opportunity to donate money. You can go to the World Spine Care website and donate.
And also fundraising of your own. World Spine Day is a really good opportunity in your clinics to set up some sort of a fundraising opportunity for World Spine Care. Just a thought, because everybody, I'm sure most people on this call are in a clinic of some sort, and that's always a good day to really highlight spinal disorders and support something that's international.
Yeah, having had the opportunity to speak to some of your clinicians who've taken the time out of their career to spend anywhere from several weeks to several months at a World Spine Center clinic, have said it's been a life-changing event, and that they had nothing but wonderful things to say about the entire experience. Yeah. Does anybody want to, if you want to raise your hand or type a question in the chat? I was going to ask you why the fluorosis problem in that population in India. They dumping it in the water, or?
Yeah. So it's a really interesting story, but that picture with my hands over the spine of that patient, I kept thinking this looks like ankylosing spondylitis, but it wasn't. There were enough things that didn't fit. And then on my flight out, we stopped in Jaipur to talk to a physiatrist who was working with that. And I just said, "Oh, what are the kind of things you see?" And she said, "Oh, mentioned skeletal fluorosis." And I went, "Oh, what is that?" And she said, "Well, the groundwater, if it's high in fluoride, the bones actually start to ankylose, or the joints start to ankylose." And so I sat in the airport and I looked up a whole bunch of articles on skeletal fluorosis, and I found this amazing article from the 1950s from the University of the West China Union University, and had all kinds of pictures of this. And what was really cool is the author's was his last name was Outerbridge.
Oh,
a
distant relative.
I was like, holy shit. Yeah, kind of distant. Like, my uncle was a medical missionary in China at West China Union University for 13 years, but it wasn't him. It was sort of his cousin. And so,
oh my gosh.
as it turned out, like Chengdu, China, where my uncle was, and Rajasthan are two areas in the world that are known that have high fluoride content in the water.
Oh my goodness.
Yeah. So
who would have guessed?
really bizarre.
Yeah,
turn of
truly.
events. But yeah, and I'll tell you another story. You guys remember Lindsay Rowe?
Sure.
And so Lindsay Rowe, when we were at the WFC
Radiologist.
conference in Durban, I went up to treat his neck. And so he decided he was going to try to, stump me on radiology stuff. And he said, "Have you ever had a case of skeletal fluorosis?" And as a matter of fact, I did. And he went, "What?" So I told him the story, and then he told me a story of a patient who had skeletal fluorosis who ate a tube of toothpaste a day.
Oh,
she was
oh my
addicted to
gosh.
eating toothpaste, and she had got skeletal fluorosis. Anyway, that was another interesting story. Yeah.
We do have a question over here. How did the Canadian government get involved in the clinic in Manitoba? Are there projects that might mimic this in the US?
That's a good question. I wasn't really on a lot of that organization, but I know there's a lot of funding from the Canadian government for development in Indigenous communities, and healthcare in Indigenous communities. And so I'm not sure how they navigated through that. Kate might have had a better answer for that, but there is a lot of support for that in Canada. So it is possible, I'm sure, in the States to do something similar. It just depends on your government.
Yeah. We'll see.
I'll leave it at that.
Oh, great. Great. One just make
I have
this
I have a question.
Go right ahead, Marcia. Go right
Oh,
ahead.
yeah. So thanks, Geoff. I really enjoyed that. Was a great overview, a lot of information in a short amount of time. Having just sat in on a virtual learning health systems meeting for a day and a half, just curious about, what kind of data that you kind of systematically collect in these various clinics, and how do you use that data? Like, are you using it to improve your programs, to improve the care, to understand more about, your populations?
Yeah, so it's mainly demographics, presenting complaints, comorbidities, and outcomes. And in the clinics, it's mainly two-dimensional. They just we're recording it on an Excel spreadsheet was where the data was entered. Since then, what we're trying to do at my clinic here in Ottawa is actually create an electronic medical record based on the same concepts that where we can actually now be three-dimensional in the data collection. So that data was used mainly for describing the population. So we have all kinds of demographic and comorbidity and presenting complaint information. In terms of outcomes, we got to a certain information. So we could say, X percentage of patients got this much better, X percentage got this much better over X number of treatments. And I think we had on average 7 treatments to discharge. But then all of this data was qualified. And this is the problem with collecting that data, because patients self-discharge. And then we got to chase them down and try to get that final data. Did they discharge because there was no pain, or did they discharge because they were good enough? How good was good enough? And so but we chased that information, and we did a lot of phone follow-ups with patients to try to gather that information. And that was also why we collected the outcomes really regularly. So if somebody did self-discharge, we had a close to end outcome, maybe not a final, but close to final, instead of collecting at the beginning and then hoping to collect it at the end and they're gone. So we kind of plugged a lot of holes by doing that. But the data gets very messy once, when people are kind of coming and going, and you're trying to talk about percentage improvements or functional improvements. And, we were looking at, we used a patient-specific functional scale. We had a brief depression screen. We had another activities of daily living, and then the visual analog scale. But even that, showing a patient a 1 to 10, or 0 to 10, and even when you put the Wong Baker faces on, and even when you put descriptions, like, no matter, there's still this confusion in the low literacy population. So we had to adapt everything to low literacy, because it had to work there as well as in the high literacy. And so we've modified that since back here. But yeah, we had a lot of challenges setting all of that up.
Yeah. Thank you. Yeah. Interesting.
That's great. Well, Geoff, thank you so much for your time. Really appreciate it.
Welcome. Thanks for inviting me.
Yeah. We'll have to do it on a regular basis. Yeah, and again, we'll really do everything we can to encourage people to, in one way or another, participate with World Spine Care, whether it by making a donation, doing a fundraising event, and or volunteering at one of your clinics.
Amazing. Well, I want to thank you guys for all the support for World Spine Care
Yeah, we're
from
happy to do
way
so.
back at the beginning.
Yeah,
We've been on this road together for a long time.
yeah.
Nice to see you, Don.
Good to see you, Geoff. Thanks so much for doing this. It's fantastic.
Always happy.
Yeah. Thank you again so much, and thank you everybody who attended. We will make this all available to everybody as a recorded event, and David Payton will be sending out the links to everybody. So thanks.
Okay.
and cheers.
Take care,
Have a
everybody.
wonderful
Thanks,
day.
Geoff. Thank you all.
Okay,
Bye
bye-bye.
now.